Good afternoon, everyone. We'll get this hearing started for the Health and Human Service Subcommittee. Today is February 21st, 2025. We have one agency readout, which is the Maryland Department of Health Medical Care Programs. And at this time, we'll have Ms. Ann Braun do our analysis readout. Thank you.
Thank you, Mr. Chairman, members of the committee. As you said, today I'm presenting the Medicaid analysis, or the budget analysis for the Medicaid budget. So on the cover page, you'll see that the fiscal 26 allowance is about $13.3 billion. That's just under $270 million less than the fiscal 25 budget. However, the fiscal 25 budget includes approximately $510 million to cover a fiscal 24 shortfall. So after accounting for that funding, the fiscal 26 allowance actually increases slightly. So I'm going to jump ahead, and I'll say I'm going to cover this analysis at a pretty high level, but I'm happy to answer any questions about any details in the analysis. So jumping to page 9, Exhibit 2 shows that Medicaid and MCHIP served 1.55 million Marylanders as of December 2024. This exhibit shows that 87% participate in Health Choice, which is the state's mandatory managed care program. The remaining 13% of participants are generally those in nursing homes or who are dually eligible for Medicaid and Medicare, and they receive services on a fee-for-service basis. In the Health Choice program, participants can choose from 9 MCOs for their health plans. And so then moving to page 11, this begins the discussion on performance analysis, the first topic being MCO quality. MDH conducts multiple activities to collect quality assurance data and monitor MCO performance. And so this analysis focuses on HHS measures that are used by 90% of health plans nationally and allow for comparison across health systems. Exhibit 3 shows each MCO's performance on multiple measures compared to the national HHS mean, showing that all but one MCO performed worse in calendar 23 compared to the prior year. Additionally, more than half of Health Choice participants are enrolled in the 4 lowest performing MCOs. MDH is asked to discuss the reason for MCO's declining HHS performance, and the department also recently announced that it was changing accountability expectations for the MCOs, and so MDH is asked to describe the method for determining HHS performance issues that might lead to penalties or sanctions. The next discussion notes that in addition to the existing requirement that MCOs must receive accreditation from the National Committee for Quality Assurance, beginning with calendar 25, MCOs must also attain health equity accreditation. And so MDH is asked to provide the current status of health equity accreditation across MCOs and when the new requirement will be enforced. The second and third performance analysis discussions have to do with the Population Health Incentive Program and health equity incentives. So this section covers the calendar 2023 results from the Population Health Incentive Program. Under this program, MCOs may earn up to a certain percentage of their capitated rate payments for achieving performance benchmarks or demonstrating improvement on measures selected by MDH. For calendar 23, these measures related to access to asthma medications, diabetes control, lead screenings among children, and other measures that are shown on page 16. 6 of these are HHS measures, and the last 2 are developed by MDH directly. Exhibit 5 on pages 19 and 20 show the MCO's results on the 8 measures, and results that are starred showed places where MCOs were eligible for improvement incentives. All MCOs reported at least one measure rated as strong or higher that made them eligible for a performance incentive, and all but 2 MCOs had at least one measure that was eligible for improvement incentives. The next exhibit on page 20 shows how about $19 million in total incentives were paid out across the MCOs. This shows that all plans received at least some performance payment, ranging from United receiving about $350,000 to MPC receiving the largest incentive payment at $5 million. The program also allows for second round payments if MCOs meet certain benchmarks, but in calendar 23, no MCOs earned a second round incentive. This left $17.2 million unallocated, but the department used $8 million to pay for the health equity incentives, and I'll discuss that in the next section. So DLS recommends reducing the remaining unallocated $9.2 million in fiscal 25 DLS also recommends reducing the fiscal 26 budget to provide for a lower share of capitated rates, considering the fiscal outlook. The next performance analysis item discusses the transition from MCO Rural Incentive Program to Health Equity Incentives. Under this program, MDH offers up to $8 million each year to MCOs based on their enrollment in certain local jurisdictions with high socioeconomic disadvantage. On page 22, Exhibit 7 shows the payments made to each MCO for calendar 24 enrollment. The distribution of the payments is not significantly different from the shares of statewide health choice enrollment, and the analysis notes that other new programs, such as the Enough grants administered by the Governor's Office for Children, aims to target investments at the neighborhood or census tract level. And so MDH is asked to provide the membership data determining calendar 24 payments, and then to discuss whether it has considered basing incentives on neighborhoods eligible for Enough grants. And so the final performance analysis discussion has to do with Medicaid application processing. Exhibits 8 and 9 show the processing time split between income-based eligibility groups who are processed by the Health Benefit Exchange, and then the more complex non-income-based groups who qualify due to their disability status or other characteristics, and those are processed by the Department of Human Services. A recent audit of the Maryland Health Benefit Exchange found that it had not requested supporting documentation for applicants that reported no income, and that OLA found state wage records indicating some of these applicants actually had reported incomes that were higher than the threshold to be eligible for Medicaid. And so during the pandemic, MDH had received a waiver flexibility to auto-renew participants who had no income or income up to the federal poverty level, but this applied to renewals and not new applicants. MDH should provide an update on this audit finding and any corrective actions taken, including whether Medicaid applicants who were found to be ineligible have been disenrolled. And so then turning to the budget discussion, I'll start with actions related to fiscal 25. This begins on page 27. Last year, $1 million was added to the budget to expand the Assistance in Community Integration Services program that provides housing supports, but this full amount was reduced in July when BPW approved cost containment actions. There was also $500,000 added for assistance to medical daycare providers, but MDH has indicated that it does not plan to spend this funding due to uncertainty of the legislative intent. There are 5 deficiencies in the budget plan, adding a total of $1.37 billion. Most of this funding is added to cover higher than expected enrollment, healthcare utilization, and inflation. As I mentioned earlier, this includes $510 million to cover shortfalls in fiscal 24. On page 29, Exhibit 10 shows the results of the MCO risk corridor agreements. This is an arrangement that MDH and the MCOs entered to share in savings or losses when healthcare utilization was uncertain due to the pandemic. MCOs annually spend a percentage of their capitated payments on eligible medical expenses, and then MDH and the federal government would share gains or losses depending on the band that percentage falls in this exhibit. Based on aggregate MCO results in calendar 21 and 22 combined, MDH received state recoveries of $51.6 million. This funding was recovered in October 2024, but it's not yet reflected as savings in the budget, and so DLS recommends reducing the deficiency appropriation by that amount to account for the savings. So then moving on to the fiscal 26 allowance on pages 32 and 33. This is our typical list of proposed budget changes from the prior year to the allowance. I'm going to actually skip ahead and cover most of the major budget items throughout the presentation. And so page 34 begins the discussion of 4 BRFA items that affect Medicaid. The first is an increase in the Medicaid hospital deficit assessment that would increase by $50 million in fiscal 25 and $100 million on an ongoing basis beginning in fiscal 26. This is an assessment that is paid for mostly through hospital rates, and the special funds collected provide general fund savings in Medicaid. And so the budget accounts for this through contingent reductions of $46 million in fiscal 25 and $92.5 million in fiscal 26. This fund swap is one of the only significant actions taken in the budget to create general fund savings in Medicaid. Another BRFA provision would create a new special fund called the Maryland Primary Care Program Fund. This would be supported with hospital payments collected by HSCRC and would be used for primary care initiatives under the state's new AHEAD model. MDH reported that $30 million from HSCRC is expected to support the fund across fiscal 26 and 27, but the budget currently has $16 million in general funds budgeted for this purpose. And so DLS recommends deleting that general fund appropriation and in anticipation of special funds that would cover that cost. To support primary care services in coordination with the AHEAD model, MDH plans to use this funding to establish a Medicaid Advanced Primary Care Program that would start in July 2025. This program would operate similarly to the existing Maryland Primary Care Program, which distributes care management payments to participating providers, and the program would also administer a quality incentive program. MDH is also providing a rate enhancement for physician and evaluation and management fees to increase rates from 98% to over 100% of Medicare rates. DLS recommends requesting a report from MDH and HSCRC on these initiatives and amending the BRFA to make 2 technical corrections to this provision. The third BRFA provision would allow MDH to transfer funds by budget amendment across its programs in fiscal 25 and 26. Annual budget language is added to certain MDH programs to restrict the funding to its budgeted use, and that prevents transfers that might create deficits in entitlement programs. The list on page 36 shows the funding restrictions applied in fiscal 25. DLS recommends rejecting the BRFA provision to keep funding restricted to its budgeted purpose as is currently set in fiscal 25. And DLS also recommends adding the annual budget language restricting funds for Medicaid and MCHIP again. This year the language is proposed to allow transfers to Medicaid behavioral health reimbursements. The last BRFA provision authorizes the governor to transfer $10 million in balance from the Maternal and Child Health Improvement Fund to the general fund. The BRFA of 2021 created this fund to be, again, supported through an HSCRC hospital assessment, and this would pay for maternal and child health initiatives in Medicaid and FIPA. In current law, the use of this funding expires at the end of calendar 25. But there are departmental bills introduced that would extend the termination to the end of calendar 2027. Due to underspending, the estimated balance at the end of calendar 25 would be $14.1 million, and so DLS recommends amending the BRFA to increase the authorized transfer to this amount. Page 37 discusses program realignments in MDH. As of January 1st, 2025, MDH had realigned its health home program from Medicaid to the behavioral health program, and a deficiency withdraws the funding for fiscal 25, but that program is still budgeted under Medicaid in fiscal 26. And so DLS recommends removing the funds from Medicaid as a technical correction and then rather supporting it through the BHA budget. The next discussion is on the long-standing Medicaid Enterprise Systems Major IT Project, or MMT project. The allowance includes $143 million for development across 14 components. Each part is discussed in appendices in the back of the analysis. There have been several delays, and in July, BPW approved a $15 million reduction in general funds budgeted in DO-IT for this project. Even after the reduction, DO-IT reported a balance of $20 million that could be used in fiscal 25 once MDH reported its plans for the funding. And so MDH is asked to provide a status update on this major IT project. Turning to page 39, this reflects special fund support for Medicaid. As mentioned, the hospital deficit assessment shows an increase. In last year's budget, there was language authorizing the use of rainy day funds to cover Medicaid shortfalls, but that amount is not yet reflected in the budget. To highlight one specific special fund source, MDH administers the Senior Prescription Drug Assistance Program. This is entirely supported with special funds, and as shown in Exhibit 14, that fund is expected to have a balance of $12.8 million at the end of fiscal 25. In fiscal 26, the budget includes transfers of $5 million for behavioral health services and $3.1 million to DBM for health reimbursement accounts that for state retirees transitioning to Medicare Part D. This use was authorized in last year's BRFA for fiscal 25 only, And so DLS recommends adding a BRFA provision to make this an allowable use of the fund in fiscal 26 and on to align with the budget. So then moving on to a discussion of provider rate increases. Exhibit 15 on the next page shows the rate increases budgeted in fiscal 26. As mentioned earlier, physician E and M rates would be raised by from 98% to over 100% of Medicare rates, as most recently the Medicare rates were reduced, but MDH is not applying the same reduction. And so considering the fiscal outlook, DLS recommends reducing the $12.2 million for this rate enhancement. The 3.5% rate increase for MCOs drives most of the spending growth for provider rates. During the rate setting process, MDH accounted for expectations that overall health needs would be higher for Medicaid recipients who remained enrolled in Medicaid after the unwinding period from the COVID-19 pandemic. This trend didn't materialize at first, and the adjustments actually gave MCOs higher payments while the Medicaid recipients they served were actually showing lower health acuity or lower health needs. As a result, MDH plans to recover about $29 million from the MCOs this month. And this adjustment was expected to be much higher at one point. And so in recognition of the acuity adjustment, MDH set the rates mid-year in 24 and for calendar 25 to be higher in the range than is to be considered actuarially sound, which is a requirement for MCO rates. MDH would normally set the rates at a lower level within this range. And so due to the recent trends in health acuity and the February adjustment being revised down, DLS recommends reducing funds to set MCO rates at the bottom of the actuarially sound range. Calendar 25 rates were set while health acuity was still appeared lower than expected. It has since increased, and so now MCO rates will likely need an adjustment to cover the higher health acuity. And so the budget includes $124 million for this acuity adjustment. So then turning to page 43, this begins a discussion on long-term services and supports provider rates, including nursing homes. LTSS providers receive a 1% provider rate increase on a discretionary basis in the budget plan. On page 43, the exhibit shows that LTSS providers have received significant rate increases in the last decade. This includes accelerated rate increases of 4% that were scheduled for fiscal 25 and 26 that were moved up to January 1st of 2024 when the minimum wage increase was accelerated. Considering the recent rate increases and there being no mandate, DLS recommends reducing the 1% provider rate increase budgeted in fiscal 26. Home and community-based services providers received additional enhanced rates that were supported with federal American Rescue Plan Act funds. Beginning in November 2021, the HCBS providers under Medicaid received a 5.2% rate increase, and that was made ongoing even after the federal funds had expired, or will expire. DLS recommends reducing HCBS provider rates under the Medicaid program by 2% due to the expiration of the federal ARPA support. So then moving on to a discussion of enrollment trends. Exhibit 17 shows how Medicaid and MCHIP enrollment steadily increased to a peak of 1.75 million average participants in fiscal 23. That was just before the unwinding period when disenrollments resumed. Fiscal 24 and 25 enrollment year to date has showed declines, but generally the disenrollments have been lower than expected. This was partially due to a system error with how the states conducted automatic renewals, which led MDH to pause procedural disenrollments. And so those are cases when participants did not complete the renewal or had outstanding documents. MDH has also implemented federal waiver flexibilities and other strategies that had helped to ensure participants kept their Medicaid coverage. As those temporary flexibilities have expired, enrollment is continuing to decline. There was also another system error that MDH is reconciling with the exchange to be sure that disenrollments correctly appeared in the Medicaid payment system. And so both the flexibilities and then the more recent system error have especially impacted the ACA expansion group. And so that group is expected to account for a larger share of disenrollments. Going against this trend, MCHIP enrollment has actually continued to grow even higher than the levels reported during the pandemic. That program has the highest income threshold at 322% of the federal poverty level. So it's possible that as children have been deemed or disenrolled from traditional Medicaid, they are then placed in MCHIP with a higher income threshold. So then on page 47, this exhibit shows enrollment forecasts assumed in the proposed budget and projected by DLS. Both forecasts anticipate the fiscal 25 enrollment will decrease below the levels assumed in the fiscal 25 legislative appropriation. That's due in part to the federal waiver flexibilities ending and then the system reconciliation process that's leading to disenrollments. Differences between the forecasts are mainly due to additional months of actual data used in the DLS forecast, and those show slightly different trends. So for example, among individuals in the Healthy Babies Initiative, recent enrollment has leveled off, and so the projected enrollment decline, or projected enrollment is reduced compared to the budget in both years. In fiscal 26, the forecast decreased from the prior year as the disenrollments would be annualized, especially among the ACA expansion group. However, you'll see within the traditional Medicaid program, specifically for the parents and children family groups, the budget projects that there will be a marginal increase as growth rates seen before the pandemic are assumed to start up again. However, the DLS forecast expects the family groups to continue declining by about 2% for each group in fiscal 26. And so then turning to the general fund adequacy discussion on page 48, because the enrollment forecasts in fiscal 25 are similar, the difference in projected spending is not due to enrollment. Rather, the fiscal 25 working appropriation appears to overstate healthcare utilization, especially for certain services like inpatient hospital services. And so because of this difference in cost in the two forecasts, DLS is recommending reducing $100 million in general funds from the fiscal 25 proposed deficiency. For fiscal 26, there were more significant enrollment differences between the two forecasts. And so, as mentioned, this was mainly among the family groups and individuals participating in the Healthy Babies Initiative. And so, as a result of those lower enrollment assumptions in the DLS forecast, there's a recommendation to reduce the allowance by $132 million across Medicaid and MCHIP. To briefly touch on staffing trends, the Medical Care Programs Administration reported a high vacancy rate of over 16% as of December 31st. Of the 111 vacancies, 13 positions have been vacant for more than 2 years, and DLS recommends deleting the funding for these long-term vacant positions. Okay, so then moving on to the issues section, the first issue has to do with Medicaid being a key driver of general fund spending growth. Besides K through 12 education, Medicaid is the biggest driver of state general fund spending. Recently, increased spending has resulted from higher enrollment and healthcare utilization, in addition to expansions in eligibility and coverage. The proposed deficiencies in the budget show that Medicaid is expected to cost more than $760 million more in general funds to cover unexpected cost overruns in fiscal 24 and 25 combined. Despite Medicaid accounting for a large share of the structural shortfalls projected in the general fund forecast, the budget as introduced does not include many cost containment proposals aside from increasing the hospital deficit assessment. Due to the fiscal outlook and Medicaid's role in growing state spending, additional cost containment should be considered. One area to consider would be recent program expansions, like the upcoming expansion of coverage for biomarker testing for conditions other than cancer. And so Exhibit 19 shows MDH's estimates for the annual cost to expand this coverage beginning in fiscal 26. The budget as introduced includes $8 million in general funds for this purpose, but MDH expects biomarker testing to cost $23 million in general funds in the first year of expansion. And so DLS recommends delaying the expansion and reducing this $8 million. This recommendation appears in the State Reserve Fund because that's where the funding was placed. Other program expansions have been implemented through waiver amendments, and so MDH received federal approval to expand the pilot program for the ACES program for housing supports. For the pilot program, the state share was previously paid with local government contributions, and then MDH would claim the federal match for this spending. As of January 1st, 2025, MDH had expanded this program with $5.4 million in general funds. And so DLS recommends reducing those funds for the expanded program and instead returning to the pilot program's funding mechanism. Pages 51 and 52 list other recent Medicaid and MCHIP expansions and their projected costs. And so given the state's budget challenges, the General Assembly should consider whether these most recent enhancements to Medicaid are affordable. Moving on to the second issue, this deals with potential federal changes impacting Medicaid. And so changes to Medicaid funding and policies at the federal level could further exacerbate a lot of the state's budget challenges. This second issue discusses possible changes, but I will note there have not been any formal announcements, and so the impact on Maryland is still uncertain. The exhibit on page 54 lists some of the potential cost impacts based on the allowance that could result from some of these changes. And so Medicaid and MCHIP are major sources of federal funding in the state budget. That's mostly due to the 50% matching rate provided for most Medicaid spending. However, there are some groups that receive enhanced federal matching of 90% for the ACA expansion group and 65% for the Maryland Children's Health Program. If either of these groups were to receive the 50% matching rate instead, then this would require the state to cover $992 million and $103 million respectively to continue covering these groups with that higher state share. Federal support for certain eligibility categories or services could also be prohibited or reduced through legislation. And so the exhibit shows the amount of federal funds projected in the allowance for certain groups or services that could lose federal support. Potential work requirements for adults in Medicaid is also listed as a change, but with indeterminate state savings, as this would lead to projected enrollment decline. I will note, though, that any cost savings from the change in enrollment would be partially offset by administrative costs needed to implement the work requirements. One federal policy change that has been considered previously is changing Medicaid from its current reimbursement model to a per capita cap or block grant. The state impact of this change would vary drastically depending on how the new funding is designed. But past analyses have found that it could cause potentially significant reductions in federal funds in the long run. Other considerations would be that limiting federal funds to certain costs per person might make the program less reactive to inflation and increasing medical costs. But it varies, again, depending on how growth factors are determined. Specifically with a block grant, state funding levels might not respond as quickly to economic downturns, which often drive Medicaid enrollment higher. And so these federal changes are still uncertain, but contribute to even higher state costs in Medicaid and MCHIP, which is why we're noting them here. The final issue of this analysis has to do with school-based health services. Medicaid is currently in the process of a two-phase plan to expand these services beyond those students currently with IEPs. And so phase one received federal approval and was implemented beginning on January 1st to expand coverage to any Medicaid eligible student to receive services from certified school psychologists and social workers. A provision in last year's BRFA allows funding from the Consortium on Coordinated Community Supports to use its blueprint funding to pay for the state share of this, and budget language limits that use to no more than $12 million. The fiscal 26 allowance provides the state share as general funds in the BHA budget instead. And so MDH is asked to provide an estimate for the annualized cost of this service expansion in fiscal 26. And so pages 57 through 62 detail the recommended actions that I've presented. I will note budget recommendations 2 and 12, and then BRFA recommendation 4 relate to issues discussed in the MDH overview, specifically on the cigarette restitution fund and home and community-based service waivers. Recommendation 13 is for committee narrative that would request continued quarterly reporting on enrollment trends. And with that, that concludes the presentation. I know I went through this analysis very quickly, but I'm happy to answer any questions.
It was a great job as usual. Seeing no questions at this time, Ms. Braun, I'm going to ask for the agency to come up. I know I see Deputy Secretary Moran and his team.
Good Good afternoon, Chairman McCray. It's good to see you always. Good to see you, Vice Chair and members of the committee. I also just want to take a moment and say just what a pleasure it is to work with all of you as your constituents have issues or you have certain policy priorities you want us to address. We certainly appreciate that. I also want to begin this particular time to also thank you, Ann. Members of the committee may or may not know, but we, along with the Department of Budget Management and the Department of Health, we have a regular touch base on a monthly basis. We call it the Medicaid consensus budgeting process. And we walk through numbers, spreadsheets, workbooks, et cetera. And Ann, we always appreciate your analysis. I also want to start by also asking for your grace, because there's a lot that's packed in here in terms of some of the recommendations. And so we are going to thoughtfully review each and every one of DLS's recommendations. So I'll ask for your patience as we review that. The first is that the department should discuss the reasons that the Maryland MCO's reporting declines in HEDIS performance compared to the national mean in calendar years. Also, we should detail its method for determining moderate or major HEDIS performance issues. What I would say there is the purpose of our performance monitoring program, particularly as it relates to HEDIS measures, is to promote better health outcomes for Marylanders. I will also note that the parameters of all those performance monitoring policies are included in our annual contracts with each of the MCOs. Those policies, in addition to quality, also review other things such as system performance reviews, looking at whether they have adequate provider networks to serve enrollees, as well as additional performance improvement projects. I'll also note that overall, the 3-year trends indicate incremental improvements for the program after the public health emergency. However, each MCO has demonstrated room for improvement, and we certainly acknowledge that. We have, through the course of this particular calendar year, 2025, which we will get reporting in the fall of 2026, we are increasing the accountability and requirements for MCOs in terms of quality. One of those includes excluding them from the population health improvement performance program that we've set up in terms of certain particular sanctions related to that. And the department is also considering other financial penalties in calendar year 2026. The goal of this program and the goal of sanctions is to further drive improvement and incentives for our MCOs to obviously deliver what our shared priorities are, which is the highest level of quality of care for participants in the Medicaid program. The next question is that the department should provide a current status of the NCQA health equity accreditation for each MCO. We'll note there that that was a requirement that each MCO had health equity accreditation. That sets a level of standards in terms of addressing health disparities across their program. 5 MCOs, including Aetna, Care First, Kaiser, United Healthcare, and WellPoint, have met that accreditation standard. For the remaining MCOs that have not yet met that accreditation standard, we'll be asking for a detailed report and plan by June, and it is a contractual requirement that they have that accreditation standard by the end of this calendar year. The third question is that the department should clarify if the current population health improvement, population health measures already align with quality measures prioritized through AHEAD, and if not, discuss the department's intentions to select measures in the 2026 calendar year to do so. I will note that there are some overlaps in terms of quality measures for the AHEAD program, particularly as we design a Medicaid primary care investment program. We are taking a look. The name of the game for us is to ensure alignment across payers, as well as the health care ecosystem. So we're taking a look to update that particular program in 2026 to ensure that there's alignment fully across the board, as well as any changes that will come down the pipe from the NCQA accreditation standards. Next recommendation is that DLS includes recommending to reduce $9.2 million in total funds from the 2025 deficiency for Medicaid reimbursements to account for the balance of unallocated funds for MCO incentives in 2023. And then also the recommendation to reduce $18 million in total funds, reducing the PHIP incentive to 0.25% of annualized capitated rates. With this recommendation, we respectfully disagree. The department in 2026 in fiscal year will actually pay out the incentives from previous year's performance from 2024. Also, we fund a health equity incentive program that was discussed in DLS's analysis, and funds will need to be allocated to support that particular program. That means the department is estimating that about $25 million of funds would need to be covered both of those particular programs. Therefore, I will note in terms of the calculation that 11 million total funds would be able to be reduced. We would concur with the $9.2 million in fiscal year 25. And in coordination with the Department of Budget and Management, we plan to reflect this particular update in the supplemental budget process. Department was asked to talk about baseline membership for the MCOs in the 6 jurisdictions with the health equity incentive. Those numbers are there for your reading. I'll also note that the enrollment across those 6 counties includes the counties with the greatest levels of socioeconomic disadvantage across the state. And then we take into account the recommendation from DLS to consider a shift in methodology to align with the Enough program, and look forward to talking about those conversations in the future. Next question is that the department should update on the MHBE audit funding related to the Medicaid application processing, including that whether Medicaid applicants were found to have higher incomes and eligibility thresholds, and that they should have been disenrolled as appropriate. We just, in partnership with the MHBE, just received this OLA audit report finding on January 28th. I would say that respectfully, we both, the MHBE and the department, after looking at federal regulations, disagree for the need of a corrective action plan or disenrollment of those individuals. What I would note there is these are for new applications for sure. However, we contend that no income attestations are acceptable per federal requirements. You can think about that in terms of our systems are set up to source state information income data, but if someone experiences a job loss, we accept the ability for them to attest that there's no income in that particular scenario. And we're looking forward to talking with OLA about those results and the interpretation of the federal regulation. The next question is DLS recommends reducing the proposed efficiency appropriation by $162 million in total funds, 51.6 in general funds. We concur. We would note that the department will be working with DBM to utilize those anticipated savings through a supplemental budget request to address the projected budget shortfalls within the Developmental Disabilities Administration, of which I believe you had the hearing on that yesterday. We concur with the ability to update or to amend technical errors in the primary care BRFA provisions. Also related to the primary care program, in the $16 million recommendation of general funds, the department, in consultation with our budget colleagues, we respectfully also disagree with this recommendation. The 26 budget bill as introduced mistakenly omitted a contingent reduction to reduce the 16 million general funds, contingent upon the receipt of special funds for this purpose, and we're planning to correct that in the supplemental budget process. We also concur with providing a report on an annual basis related to primary care, and we're looking forward to providing that to the respective committees. The next is rejecting a BRFA provision in terms of restrictions to budgeted purposes, allowing for certain transfers as specified in budget language. DLS here also recommends that adding budget language for fiscal year 26, restricting those Medicaid reimbursements to that purpose. Under recommended language, funding can be transferred in the BRFA as proposed between Medicaid and the Maryland Children's Health Insurance Program, including between Medicaid behavioral health. I'll note here that the department respectfully disagrees with this recommendation to restrict those budget alignments. The restrictions posed by DLS do place the department with a stress in the budgeting process and does impede our ability to address budget shortfalls. I will also note here that we would be happy with reconsideration with all of you to think about contingent language, that providing a report, for example, that would allow the department to do this, and we look forward to continuing to talk with you related to that. This flexibility, I would note, is critically important for the department moving forward, and is especially needed now when there are so many budgetary pressures at the federal level that would allow us any cushion to make changes in enrollment, utilization, and other drivers. So we're happy to talk about a potential contingent report related to this item. DLS recommends amending the BRFA provision to increase the authorized fund balance transfer of about $14 million to transfer all remaining funds at the end of calendar year 2025. I'll note that the department is supportive with current legislation that is introduced in the House and the Senate to continue the sunset of this particular program. This program is critically important to funding maternal child health issues. The proposed increase from DLS to $14.1 million would impede the department to provide these particular services in future fiscal years beyond fiscal year 26. So the funding would allow for fiscal year 26 for those services to continue, but beyond that, it would impede our ability, and the department supports the transfer if the legislation that we are supporting is enacted. The DLS recommends deleting about $18.2 million for health homes. We respectfully disagree with that. I'm sure you'll hear about it in the Behavioral Health Administration budget, but the funding there needs to be retained in the legislative appropriation in the BHA budget. We've also provided, I'm not going to detail them, each of them, but we have a very extensive Medicaid transformation in terms of our information technology, total of 14 projects. They're there for your reading as well, but they cover each of those, what the status update is. And in the DLS section of each of those, there's a summary of what each of those particular projects do as we look to modernize and update our Medicaid information technology system. There's also spending reports available for each of those particular projects, spending through what's already been accounted for in 2025 and what's anticipated for the rest of 2025. DLS recommends adding a provision to the BRFA to expand the allowable uses of the Senior Prescription Drug Assistance Program in fiscal year 26, and in future years to include depositing funds into certain accounts for certain state retirees transitioning into Medicare Part D plans. In consultation with the Department of Budget and Management, the department respectfully disagrees with the recommendation. That was an error in the statewide account, and the department, DBM, is working to correct that in the legislative appropriation with the appropriate funding source. Next, I'll start talking about some of the cost containment or budget reduction items and the department's reaction to those. First is, due to the fiscal outlook, DLS recommends deleting about $12.2 million budgeted for the enhancement of physician evaluation and management rates in fiscal year 26. We respectfully disagree. No, last year we had this conversation in this committee. Senator Jennings, I know you asked a specific question about this last year, but the physicians in fiscal year 25 last year were the only providers in Medicaid to receive a cut. All others received a 3% increase, and the HSCRC gave hospitals increased rates as well. The $12.2 million in the current budget in fiscal year 26 look at maintaining the physician fee schedule from fiscal year 24. Also, this initiative and this opportunity of increasing E&M is vitally important to the state's success under AHEAD, particularly as it relates to comprehensive access to primary care and a robust referral network related to physician specialists. Next is the DLS recommends reducing $90.7 million in total funds to lower MCO rates in the calendar year 25 to the bottom of the rate range. The department respectfully disagrees. The department has updated 2025 mid-year acuity adjustments with data through the end of December. Our actuaries are estimating that $165 million in total funds is needed rather than the $124 million, only because we're seeing, in partnership with our MCOs, an increase in acuity. I would also note that if rates were set at the bottom of the rate range, then with those particular calculations, almost $100 million would still be needed for the mid-year acuity adjustment. And that means that most funds available to cut based on this recommendation should only be about $25.1 million. However, we would remind the committees that there are many different factors that can increase MCO rates at the mid-year adjustment in 2025. Most notably, hospitals obviously will be making particular changes for the next fiscal year that they vote on their May meeting. And the current rates that we have built in do provide collectively amongst all 9 MCOs about a 1.3% profit margin, so moving any lower in the range, we certainly know that some MCOs would lose money. Due to there being no mandated appropriation or no mandated for the additional rate increases for other providers, specifically LTSS, DLS is recommending not taking the 1% proposed in the governor's budget. The department acknowledges that recommendation. DLS also recommends a 2% cut for home and community-based services providers. The department respectfully disagrees with that recommendation. We would note that there are new federal rules at the federal level that state for reductions at that particular level, that the state would actually need to receive the approval of the federal government at CMS in order to make those rate reductions. So that is a process that we would need to go to. That process is also new in terms of most recent federal regulations previously. And then also I would say here that that reduction does not support our efforts in terms of end the wait. And our goals at the department shared by the legislature to decrease end the wait, rate sufficiency and provider capacity is paramount in those goals to ensure that we're serving additional programs that enroll into the program to achieve the goals set out by end the wait. DLS is recommending in the next to reduce the proposed deficiency by $100 million in general funds for 25. We respectfully disagree with that recommendation. We also would love the opportunity to continue to discuss with DLS and Ann specifically to understand more of the detail and analysis there behind that recommendation, because our data, which we've showed you there in a chart, continues to see strong utilization trends in our fee-for-service population. The data there is our inpatient utilization trends that show increased clinical acuity for physical and behavioral health, and these certainly follow national trends. The next recommendation is to reduce the allowance for Medicaid to $90 million in total funds and $48.2 million in total funds for 26. The 42.8 is the Maryland Children's Health Program. We would respectfully disagree with these, with this recommendation in terms of reducing or the enrollment projections that DLS is seeing. As I mentioned earlier, we have a consensus budget process that looks at those. We've shared what our actuals to this year to date are, and we continue to strongly affirm what we are seeing related to enrollment. I'll also note to the committees that this is a critically important time, that even before any of these projections were solidified, there wasn't an appreciation for what was going to happen at the federal level and how that may impact the state's Medicaid enrollment. Ann also mentioned this in her analysis, at least verbally, but as Maryland has a disproportionately higher share of federal workers and government contractors, the impact to the Maryland workforce by current and future decisions that we are seeing will only potentially increase the Medicaid enrollment that we have here in our state. Therefore, it's our opinion at the moment that we are currently in is too full of risk to make any savings related to enrollment changes. We would note that we, in one of the areas, we concur partially in terms of enrollment in our Healthy Babies coverage category group and have recommended to make some reductions there that will be reflected in a supplemental budget item. DLS recommends deleting funding for 13 positions. The department respectfully disagrees with the recommendation to delete those positions. While I can recognize the concern of the long-term vacancies of this position, I will tell you that I have made it the highest priority in my office to ensure that from our two offices, the Office of Eligibility Services and the Office of Long-Term Services Supports, to fill those vacant positions. In fact, 5 of those that are outlined, we have pending commitment letters ready to go out the door to bring Marylanders on board to work for our teams, specifically focused in on eligibility operations and our waiver programs. 3 of those jobs are actively posted, and 5 positions are actually being transferred to the Department of Corrections and Public Safety. That is going to be reflected in a supplemental budget request. Those positions are designed to support individuals leaving incarcerated facilities up to 90 days in advance of that, in alignment with our approval of our 1115 waiver from CMS, which allows us to provide support for people leaving incarceration, and those positions will support that important work. The next recommendation is DLS is a provision of the BRFA to delay the biomarker testing from 25 to 27. We respectfully disagree with that recommendation. This was passed in 2023 to provide broader coverage for biomarker testing. It was a priority for the Legislative Black Caucus and was passed in both chambers with unanimous votes. The $8 million that the governor's budget introduces in a dedicated purpose account allows us to focus on additional testing to have the greatest impact on eliminating health disparities and improving health outcomes. The next recommendation is the reduction of about $10.8 million in ACES expansion and returning to the pilot program's funding mechanism for local spend. The department, once again, respectfully disagrees with that recommendation. The local spending funding program to support ACES. ACES is a program that provides intensive case management and housing supports to individuals who are experiencing housing insecurity. And I will tell you that local funding for those particular initiatives went away last fiscal year because that is funded in the governor's budget for this particular fiscal year. And then in 26, where we are working on a statewide expansion for more areas across the state to take advantage of that particular work. CMS also approved this waiver request, and we are working on expanding this work statewide. I will also note that this is one of the programs that has significant health outcomes improvements. It also has a significant amount of evaluation and data from the Hilltop Institute that showed dramatic reductions in inpatient hospital spend, all in alignment with our total cost of care and future of ahead program. The next is that given the state's budget challenges, there were a host of recent benefits that have been passed by the General Assembly, and the DLS has asked the General Assembly to carefully consider whether some of those enhancements to Medicaid are affordable. We would advise you that with these particular benefits that there would be requirements to change at both the state and the federal level. Just as we have to go to get authority to start benefits at the federal level, you need to unwind in the same authority to take benefits away, if you will. And also, these are enshrined within statute, all of these, so there would need to be changes there. There are contractors at play, operational logistics. If the General Assembly is going to be considering any of those particular types of benefits or others, we would respectfully ask to be consulted on those, because some of those are 6 to 12 months opportunities before you can see any unwind of benefit programs. And then lastly, thank you all for your patience. The department is to provide an estimate on annualized cost to the phase 1 expansion of school-based behavioral health services. In 26, that number is approximately 12 million general funds. I will note also that in January 1 of 2025, we leveraged about $3 million or about $2.5 million of grant funding from the federal government to launch behavioral health services in schools. That means that school psychologists and social workers can begin providing behavioral health services to Medicaid participants, creating access for every child in the state of Maryland. And that work is already live and will be accounted for in BHA's budget. Lastly, before I answer any questions that you may have, of which Emily Bradenberg, who's our Chief Financial Officer at the department, and I are happy to answer, I just want to take the moment and thank the entire 700 team at Medicaid who works tirelessly day in and day out to serve a critically important 1.5 million Marylanders across the state. They are amazing, and I am in awe of them every day, and so kudos to the team for their efforts. Thank you, Chair.
Thank you. I guess one question in reference to the 1915 Medicaid State Plan Amendment. There's public testimony that applauded your efforts in reference to putting forward the amendment, but they also raised questions about the rates. If you could just chime in on that.
Yeah, so good news on that, Chair McCray. The 1915 State Plan Amendment was submitted this week, which is just a huge win in terms of months and months of stakeholder feedback to improve the services that we provide to kids. I will note that from a rate perspective, given the budgetary limitations, the 1915I rate for services will remain consistent related to that. I will note that the department does have a contractor right now that's doing a comprehensive behavioral health rate study, and we plan to take a look at those rate provisions as part of that particular study for future budgetary considerations.
Thank you. Senator Zucker.
Thank you very much. Good to see you all. I know that some of the recommendations, you alluded to this, but are you guys doing like modeling to make sure that you're in the best position? We're in this together. We're in the best position possible. Should there be cost shifts from the federal government?
Yeah, we have. So we, just like the Department of Legislative Services analysis have looked at, the things that I think are most publicly talked about. So thinking about, the biggest one I think is of the most grave concern for states is the change in any calculation that they would make from the state share versus the federal share. The biggest portion that gets discussion related to that is the Affordable Care Act expansion, which, we as an expansion state get 90% of federal match for about 400,000 Marylanders just south of that. So we've done modeling to say what would happen, if they would go to 50-50 in terms of that. There are significant financial consequences for that. There are other concerns that we have, right, and Ann discussed them as well: imposition of work requirements, more frequent eligibility checks, which just quite frankly create more administrative burden for the state more than anything. And so we're modeling out what those would do. There are other items that I think that are being floated. We're closely following what's happening in both chambers in the House and Senate at the federal level. There might be some diversion in terms of how they're navigating the Medicaid process related to that. But we have our pulse all over it, and it's the number one thing that keeps me up at night.
Thank you for that. I also want to acknowledge that you guys used the word acknowledge for the provider rate, the 1% decrease. I don't think I've ever heard that before. What does that mean in context to a position?
So I would say, obviously, we can disagree or agree. We recognize that collectively all of us are in a moment of tough budgetary decisions. So we recognize and acknowledge that if that is a reduction that the General Assembly wants to make, we would acknowledge that.
Got it. The other thing is that thank you so much for, in one of your responses, you graciously mentioned End the Wait and the impact that a recommendation would have on End the Wait and the commitment to end the wait. So what right now is the commitment to end the wait? Where are we with it? And,
Yes. Also had the opportunity to connect with Deputy Secretary Hutchinson, who gave me the opportunity to ensure that we had an answer for your question. I take this very seriously, Senator Zucker, and our teams do too. I want to talk about specific waiver programs and the progress that the department has made. First, on the autism waiver, we have officially, in partnership with MSDE, moved that from a registry to a wait list in November. So that's huge news, right? So we have screened individuals for technical medical criteria, and they're now on a wait list, significant amount of lift. The community options waiver, which is an opportunity for individuals, older adults within the community. We've still got about 20,000 people who are a part of a registry. However, we have seen about a 10 to 15% reduction in about an 18-month period. And we've implemented strategies to reduce the community options waiver. The first is we're now inviting 700 participants per month, which was an increase from about 300 about 18 months ago per month. We are also using data from Vital Statistics Administration to ensure that that list is scrubbed on an ongoing basis. We expanded a contract with our utilization control agent, Telegen, to ensure that they are the ones that are doing the medical and technical criteria reviews. I get a report on a weekly basis about the reduction that we've made from there. And we've also reported that to the Appropriations Committee when this came out in terms of how many plans of service are under review there. I would also note that the End the Wait plan that the department put together in 2023 does provide some significant additional staffing resources that the department needs. The reductions in terms of the eligibility determination staff that was in the DLS recommendations, that is one of which that if we were to lose those particular staff, and I recognize that those were long-term vacancies, that would significantly impair our ability in terms of our goal, because we have taken an immense transformation as it relates to the eligibility determinations division.
Yeah, how much was used for that? $7 million?
For In the Wait?
For staffing.
Don't know what the number is for staffing across the board, but for that specific proposal of 13 staff, I think it was $775,000 total funds.
Okay. All right. Well, we can talk offline about the rest. I had one more question, Mr. Chair, and then Medicaid deficit assessment.
Yes.
Just wanted to know kind of where we were compared to our federal cap, and then also and you don't have to answer this right now, but if you could supply it to the committee, just in terms of what other revenues, whatever taxing revenues we're getting from other Medicaid programs.
Yes, happy to do that. So from the deficit assessment, the budget does introduce an increase of $50 million in the hospital deficit assessment for this current fiscal year, and it increases that to $100 million in fiscal year 26. The $100 million increase in fiscal year 26 would get us back to almost 5, 6, 7, 8 years ago of what the deficit assessment used to be in terms of the state of Maryland. I will note that is a key component that other states use to support Medicaid funding. It's a tool about 40 plus other states use. We've also done an inventory of other states, both from a legislative perspective as well as what the agencies are recommending in terms of who is thinking about increasing that deficit assessment. What we have experienced in the state of Maryland related to strong enrollment, increased utilization trends that we've talked about is not unique in the rest of the country when I talk to my colleagues, and so the hospital assessment is a key way to do that. The analysis does talk, and we're happy to follow up specifically on the numbers, does talk about other special and reimbursement funds that supports the Medicaid budget. One of those that I will highlight in addition to the hospital assessment is a nursing home assessment that's also provided there. So that's another bench level of support. There's also a long existing coverage fund that's through the Health Services Cost Review Commission that provides those particular types of supports after the, actually prior to the Affordable Care Act in that sense. So there are other sources that do provide that.
Senator Heidelman.
Thank you very much, Mr. Chairman. Thanks for being here. And your office is always very responsive to my office and our constituents' needs, so I do appreciate that very much. Can you give us an update on the 1115 waiver? And I noted that you mentioned you were in your objection to the suggestion that the staff be,
Right.
13 positions be eliminated, that 5 or so of them are attributable to that particular program. But can you give us a status report briefly on where things are?
Yes, happy to. I think Maryland now became the 13th state. I think that's the number to receive a waiver approval to provide Medicaid coverage for individuals pre-release, providing case management, medication-assisted treatment, and prescription drugs for individuals. We received approval for that waiver request just before the end of the Biden administration. And the next step in our process is that we develop an operational implementation plan in partnership with Corrections and Public Safety. We have to submit that operational implementation plan to CMS for approval as well. But the goal is, and the governor's budget has introduced, leverages opioid restitution dollars, about $4.5 million general funds to get that program off the ground, is to start within those particular facilities in July, so the next fiscal year, pending approval of that operational plan.
So you anticipate getting that back in for approval and being operational by this July?
At least in some pilot sites with Corrections and Public Safety. I expect it to be a slow ramp up, but there's an opportunity for us to have something into place then. Yeah.
And is that only in state institutions?
That's correct. Yes.
Okay.
Yes. I know you and I have talked about local facilities potentially in the future, and I think our opportunity is to think about how can we get this up and running in some states, show some success, and then have some phase 2 and with some additional funding in place.
Thank you very much. Thanks, Mr. Chairman.
Thank you. Seeing no further questions from the committee, Mr. Deputy Secretary, at this time, we're going to start calling up public testimony. If we could have them come up in fours, if that'd be possible, and I'll start listening to the names. Ms. Barbara Bricata, Nicole Granner, Daniel Shattuck, and Joseph Wynn. Daniel, I'm assuming that you're here for Barbara, so I'm
Yes,
going to also
indeed.
call up Stephanie Clapper.
Would you like me to start?
Yes, please.
All right. Thank you, Mr. Chair. My name is Dan Shattuck here on behalf of Bricado and Shattuck. Really on a number of issues, and I'll go through those quickly, but I want to thank you, Mr. Chair, Vice Chair, members of the committee, for your always open doors and your listening ears as we come to you with issues and challenges and your willingness to take action. And I want to thank Secretary Ryan Moran and his team for their openness to me. He's always been willing to sit down and talk through issues with us, and I appreciate that greatly. So I first want to start with the E&M codes. I want to say a big thank you for the increase back to 100% of Medicare. The cost is worth the return on the investment, and I urge this committee to maintain those rates. Secondly, maternal fetal medicine. I want to thank the department for a deep dive they did into looking into maternal fetal medicine codes. Many of those codes have not been adjusted in over 10 years. Maternal fetal medicine physicians treat the most at-risk moms and babies, and we look at this report as a springboard for future discussions and hopefully some future action. I wanted to touch on home and community-based options waiver, aging in place, receiving care at home in the community, and more importantly, avoiding institutionalized care is a key issue with us. We know there's more to be done, and again, we look forward to continuing work with the department on this. I know great strides have been made, especially with the 700 invites a month. That's a big step forward, but again, there's more to be done. And then finally, I want to touch on anesthesiology. We've been before this committee before to talk about the challenges that are emerging with anesthesiology and ensuring access to surgical care. As the proportion of patients that anesthesiologists treat are increasingly Medicaid patients, what becomes obvious is the disparity between Medicaid rates and commercial rates. And we absolutely know that Medicaid cannot make up that difference. So we do need to look to the commercial payers and look at the landscape that exists in the healthcare environment now. Commercial reimbursement has been the lowest, or Maryland's commercial reimbursement has been in the lowest quartile for years and years and years. So we really need to look at ways to ensure that Medicaid recipients in general are getting access to the care they need. We know there's uncertainty at the federal level. It's reassuring to hear that contingency plans are being made, but again, we don't know what we don't know. But it's important to make sure that the strongest workforce is here for Medicaid patients. We want the best, the brightest, robust workforce. So thank you again for the E&M codes, and again for letting us be at the table to continue these discussions and dig deep into these issues. Thank you.
Good afternoon, Chairman Cray, members of the committee. My name is Nicole Grainer, and I'm the Director of Government Affairs and Public Policy with the Community Behavioral Health Association of Maryland. Our 87 members serve the mental health and substance use needs of the majority of people getting services through our public behavioral health system. I also want to start by acknowledging Deputy Director Moran and his team for their leadership through the transition to our new ASO. As with any transition of this size, there have been hiccups along the way, and we appreciate his team's oversight and dedication to ensure a smooth transition. Their partnership has been invaluable. I was up most of last night trying to find words to express how important 1% is. To a lot of us, 1% isn't much, a rounding error at best. But to behavioral health providers, 1% can mean the difference between offering a cost of living increase to their direct care staff, many of whom already don't make a living wage, or asking them to hold on until next year when maybe that money will be there. Maryland is in a behavioral health crisis. We have half the number of workers we need to meet the demand for care. Families are waiting weeks or longer for essential treatment. Providers are struggling to keep their doors open. They're losing staff to better paying jobs, and they're unable to meet the overwhelming need for services. Yet today there's a recommendation to cut the already modest 1% provider rate increase. This is not just a budget adjustment. It is a decision that will further erode Maryland's already fragile behavioral health workforce. For decades, behavioral health providers and the individuals they serve were left behind. Before the mandated rate increases from the HOPE Act in FY17, provider rate increases increased by a total of 12.5% over 20 years. The increases from FY17 to 24 allowed providers to begin to recover from those decades of underfunding. The MHCC workforce assessment confirms what we already know. Pay is the #1 factor in addressing this crisis. Without continued investment, we will lose more workers, more programs will close, and Marylanders will be left behind without the care that they desperately need. I urge you in the strongest possible terms to reject the proposed cut and fully support Governor Moore's budget. Thank you.
Members of the committee, my name is Stephanie Clapper. I am Deputy Director at Maryland Citizens Health Initiative, and our mission is quality, affordable health care for all Marylanders. I'd like to start by thanking you for your leadership. Thanks to your leadership, we have so much in Maryland to be proud of through programs like the Easy Enrollment Program. So we've made so much progress, increased access to health coverage since the passage of the Affordable Care Act, and past innovative programs. We ask that you fully fund Medicaid, and we oppose cuts to Medicaid funding that would harm Marylanders. It's critical that we continue to protect our most vulnerable residents, low-income families, low-income children, seniors, and people who depend on this coverage to fight conditions like cancer. When Marylanders have access to health coverage and to actually accessing that care through the coverage, we see hundreds of millions of dollars in savings through the healthcare system because people are no longer forced to get care in the emergency room, which is the most expensive place to get coverage. This helps stabilize premiums for everyone and helps reduce emergency room wait times for everyone, which is critical as Maryland is facing some of the largest emergency room wait times in the country. We oppose reductions in provider rates, which would make it harder for people to access the care that they need in the community. We oppose reductions based on estimates that enrollment in Medicaid programs will go down, because given the current economic climate in Maryland and the effects of federal layoffs, we could see Medicaid enrollment actually need to go up. We really thank you for passing critical programs such as adult dental coverage, the Healthy Babies Equity Act, and the Trans Health Equity Act, and thinking about removing access to coverage for people under these programs would have real harmful implications for Marylanders. So we thank you for your leadership, and we urge you to please fully fund Medicaid. Thank you.
Good afternoon, Chair McCray, members of the committee. For the record, my name is Joe Wynn. I'm the Executive Director of the Maryland MCO Association. We are the association that represents the 9 Medicaid managed care organizations in the state. I'm here today in support of the governor's budget, which preserves Medicaid funding. Medicaid funding preservation is important for program integrity, but it's also important to maximize and maintain federal matching dollars. Medicaid's the safety net in Maryland. That's about 20% of the population, and that statistic is true throughout the country. About 40% of all births are financed by Medicaid in Maryland. In fact, the population is mostly moms and kids. There are the expansion population adults, most of whom work but still need assistance. This is a time of change and uncertainty in Maryland and throughout the country. On one hand, we're partnering with the department and other stakeholders to help implement the AHEAD model. And we're also coming out of the public health emergency and the ending of the COVID emergency. Following the public health emergency, we've had a lot of uncertainty and swings in our membership, which were discussed both by DLS, thank you, and by its Deputy Secretary. These remaining members in Medicaid have a higher acuity, in other words, a sicker population. The uncertainty around membership and enrollment, the remaining population with a higher acuity, and our financial projections indicate that fully funding Medicaid is important. Lastly, we've heard a lot about the discussion that's going on in Congress right now, and it is true that even minor changes in programmatic areas of Medicaid would have catastrophic effects for Maryland's healthcare ecosystem. We respectfully request that the General Assembly and this committee support full funding for Medicaid, and I'm here to answer any questions that the committee might have. Thank you.
Thank you. Seeing no questions, if we can ask Ms. Melanie Diggs, Allison Chang, Kevin Lindemode, Ashley Willard.
Hello, my name is Dr. Melanie Townsend Diggs, and Chair McCrary and members of the Senate Budget and Taxation, Health, and Human Services Subcommittee. Thank you for this opportunity to testify the importance of protecting Medicaid in the MDH budget. I'm currently a regional director of a public library system in Maryland, and I've served on the board of the Families USA. Actually, that was from 2014 to 2021. But in 2006 to 2009, I was personally a recipient of Medicaid, my family and I. Medicaid and the MCHIP program covered my children with medical and dental insurance and care. And In between that time, I had a fourth baby in 2009, and I needed, in 2009, where I needed prenatal care, and I received Medicaid for that. And so I'm grateful for Medicaid being around during that difficult time for my family. Without it, I would not have access to all of that care that I just described, and especially when my now 17-year-old senior in high school was a baby. She suffered from extreme eczema. And I don't know if anybody knows what extreme eczema is like, but it's a skin disorder. And she would cry at night. And I didn't know what was wrong with her. Any smells, any perfumes, fragrances that she would smell, she would scratch her skin would be raw and bleeding. And because we didn't have health care, I didn't know what to do until we were covered under Medicaid. And we were able to get her to see a dermatologist. The dermatologist was able to care for her. The dermatologist asked me, we can go the long route, or we can give her, shots that would recover her skin. And now, if you look at her, she has beautiful skin. You wouldn't even know that she had that extreme eczema. So I know the importance of covering Medicaid. You all talked about people who are now finding themselves out of jobs in federal government. And so I think I could represent that person who once had a job, but at the time did not have and could not afford health insurance. And so as a librarian, I also have assisted people in able to get on the healthcare access. And it's important to continue to have healthcare access and that people can gain insurance through Medicaid. So we in Maryland need to do everything that we can to ensure that Medicaid continues to provide health coverage to its most financially and medically vulnerable residents. And so thank you very much for your consideration. I urge you to protect Medicaid from cuts.
Good afternoon, committee members. My name is Alistair Chang, and I am here on behalf of Fabric Health, which is a community-based organization that helps families get, understand, and use their healthcare benefits in laundromats. We use the 2 hours that millions of families spend waiting in laundromats each week to turn a routine chore into an opportunity to recertify their Medicaid, apply for public benefits like SNAP, and schedule appointments. We focus on laundromats because time is actually one of the biggest barriers to care for your constituents, especially for those working multiple jobs. And we have the unique asset of over 100 hours a year with millions of Marylanders. And week after week, we're seeing how your constituents are missing critical healthcare communications due to outdated contact information, language barriers, limited digital access, et cetera. And by meeting people where they are, we help bridge these gaps and improve health outcomes. And our work is just one example of how proper Medicaid investments are essential to keeping Marylanders insured and connected to preventative care. I want to share one example of how these investments flow down. Just this last week, we were assisting a mother in Prince George's County who was unaware that her Medicaid had lapsed after missing a renewal notice that was sent to an old address. And by the time she realized she was uninsured, she was pregnant and caring for 2 children, both of whom had gone years without a doctor's visit. As state data indicates, procedural disenrollments are among the leading causes of coverage loss during redeterminations. And through a partnership with the Maryland MCO Association and individual Medicaid MCOs like Care First, we've helped her complete her re-enrollment process, apply for additional public benefits, and schedule medical appointments for the family. And today, she's no longer rationing food for her children because her Medicaid is restored. Without sustained Medicaid funding, services like ours are under threat of being cut. So we urge you to not make the cuts that the Deputy Secretary mentioned earlier, and appreciate your time and consideration.
Good afternoon, Mr. Chair. Good to see you. Members of the committee, I'm Kevin Lindemood with Healthcare for the Homeless. We are Maryland's leading provider of integrated health services and supportive housing for men, women, and children experiencing homelessness. I have seen over decades the amazing things that happen when people get access to the comprehensive care that they need as Medicaid has expanded into new and innovative ways of engaging vulnerable people into care. We are here in extremely strong support of the department's budget, of Deputy Secretary Ryan Moran and his incredible team, and urge you particularly, I want to draw your attention to the Assistance in Community Integration Services waiver, otherwise known as the Maryland Supportive Housing Waiver. I was here just a year ago before this very subcommittee praising the department and the governor for including the match in the budget, which would allow for the continuation of a successful pilot and statewide expansion. As Deputy Secretary Moran mentioned, the Assistance in Community Integration Services program was studied over a 5-year period by the Hilltop Institute. Statistically significant reductions in emergency department visits, hospitalizations, hospital readmissions within 30 days. The goals we are all trying to collectively pursue. It engages an extremely vulnerable population. In Baltimore, we support 300 of the 620 statewide slots right now. We very much are excited about the opportunity to expand the program further, improve the health of the most vulnerable among us, and as the Hilltop Institute reported, save the state money at the same time. We think that taking a cut like this would be misguided. The money is not there. Hospitals contributed much of this support, and we urge the state to move forward with expansion. Thanks for the opportunity to testify.
Good afternoon, members of the committee. My name is Ashley Woolard. I'm from the Public Justice Center. I'm the lead attorney for our Health and Benefits Equity Project. We support the governor's budget and oppose cuts to the Medicaid budget that impact community members' access to care. Over the last 5 years, the General Assembly has passed and funded incredible and innovative reforms for our healthcare system and Medicaid beneficiaries. Before adult dental Medicaid coverage, I was hearing devastating stories from community members who could not afford necessary dental care. Many of them had broken or missing teeth and were going to the emergency room for pain management and antibiotics for chronic dental pain. The General Assembly passed comprehensive dental coverage for adults to give them access to care and to prevent deaths like the dental infection that took the life of 12-year-old Diamante Driver, who was actually the child of one of our clients. Undocumented birthing people had to wait to learn vital information about their baby's health until they went to the hospital to deliver because Medicaid did not cover prenatal and postpartum care for them. Prenatal visits are where care teams identify medical issues that need to be addressed before or as soon as a baby is born. We also know that statistically, the postpartum period is the most dangerous period for birthing people in Maryland. Through the Healthy Babies Equity Act, we are providing a path to timely care that helps us prevent pregnancy-related disparities and deaths in immigrant communities. This body also expanded access to care for access to gender-affirming care coverage through Medicaid and the needed funding, which has enabled low-income trans Marylanders to finally access necessary and life-saving care. We know that you have to make some very difficult budget decisions this year, but we do ask that you preserve the funding for our Medicaid programs, many of which are intentionally rooted in our state's commitment to advance health equity. Medicaid isn't just an entitlement program, it's a lifeline to care for Maryland's individuals and families. Thank you.
And thank you. Dr. Diggs, just one comment before we get to the next panel. I just want to say thank you for having the courage to not only share your story, your children's story, but more importantly, I grew up in our libraries in the city, so thank you for your leadership from that standpoint. Colleagues, seeing no questions, we'll move on to the next panel, which will be Callie Schumitz, Dana Kaufman, Drew Vetter,
Thank you, Mr. Chair, members of the subcommittee. My name is Callie Shumatz with the Maryland Center on Economic Policy. We are here in strong support of the governor's proposed budget for Medicaid. I think we were alarmed by some of the suggested cuts that were put on the table for consideration in the DLS analysis. You know, we recognize the state's budget situation and that there are real threats to Medicaid from Congress. And if those cuts happen, they will harm a lot of Marylanders and require impossible decisions at the state level. However, we are not there yet. Those potential cuts are deeply unpopular and may never happen. So we should not get ahead of the process and start preemptively taking away Marylanders' health care. We see a healthy community with access to affordable care is really critical to a healthy economy. I just want to also comment generally on some of the approaches Maryland has tended to use in addressing budget challenges. Freezing or cutting provider rates has in the past made it harder for people to access essential health care because they can't find enough providers willing to accept Medicaid. And also focusing on programs just because they were enacted more recently, we think is a misguided approach. The programs that you've heard about from others today, like Healthy Babies, General Affirming Care, the access to community integration services, dental care for adults, these were all thoughtfully enacted with a lot of community input to address current needs in our communities. These programs are working. They're all expected to decrease costs over time by reducing emergency room visits, preventing people from developing more severe and costly to treat health needs. So we have no issue with the kind of fund swaps and technical fixes proposed, but we strongly urge you not to go down the path of taking away essential health services from vulnerable Marylanders and pausing programs that are working and improving the health of our communities. So we urge you to stick with the governor's proposal that does not make those harmful cuts. And just quickly would echo the concerns about assuming lower enrollment with the layoffs and the things that are happening at the federal level.
Good afternoon, Mr. Chair, members of the committee. I'm Drew Vetter here on behalf of MedChi and the Maryland Academy of Family Physicians. We support the Medical Care Programs Administration's budget as introduced by as proposed by the Moore administration. The administration's operating budget recommended that evaluation and management rates be funded at over 100% of Medicare. There's a recommendation to cut those rates. The administration's proposal in part was made to account for a cut that was made to provider rates last year. Maintaining this cut into fiscal 26 will have a negative impact on healthcare access for Medicaid patients, particularly in those low-income populations in both urban and rural areas of the state. E&M rates are really intended for primary care. Primary care is a critical component of the AHEAD model, where healthcare budgets are stronger when patients receive preventative care that keeps them out of hospitals. Lower reimbursement means lower participation by providers, as physicians may struggle to cover expenses. Not having enough participating providers in the program means that Medicaid patients may experience longer wait times for services, having to travel further for care, or struggling to find a provider. We respectfully request that the subcommittee support the administration's proposed funding, level of proposed funding of E&M codes. Thank you.
Mr. Chair, members of the subcommittee, my name is Dana Kaufman. I'm here on behalf of Lifespan, the Maryland Association of Adult Day Services, and the Maryland National Capital Home Care Association. All three organizations support the governor's proposed budget. I want to focus my comments on two recommendations that were in the analysis, which we do oppose and we ask that you do not accept. The first is a 2% rate reduction to home and community-based services. And to be very clear, these services, the home and community-based, these are your medical adult daycare centers, your home care that are provided through residential service agencies and your assisted living programs that do participate in Medicaid, which is a dwindling percentage already given the inadequate rates, as well as other waiver programs. These programs are instrumental in meeting the goals of the state to allow individuals to age in place in the least restrictive setting. These programs are also those who are hit hardest by COVID-19 and have struggled since to be able to get back to pre-COVID-19 levels. I don't have to remind you that medical adult daycare centers were actually closed for a year and are still struggling. If you look on page 15, This cut saves the state $3.6 million. I can guarantee you that with this cut, centers and other programs will have a very hard time staying in operation. And it's not like Medicaid recipients won't need services. They will just end up getting services in more costly centers like hospitals and nursing homes, which will be a higher cost to the state. So we definitely ask that you oppose that recommendation. With regard to the 1% for long-term care services and support, we also ask that you continue to support the governor's recommendation. And I just want to point out that the increases were directly resulting from the minimum wage increase, not through cost of care adjustments. So thank you very much.
Thank you, colleagues. I just want to lean in and say to Deputy Secretary Moran, just thank you for the work that you and your entire team that you all are doing for the Maryland Health Department. Ms. Braun, as usual, I do appreciate the high level, but it was very in-depth, even at high level. And colleagues, and to each and every advocate, I saw a number of friends that were out there in the crowd that gave testimony. I say thank you, and especially memorable, just Dr. Diggs. Those personal lived experiences are always hard-hitting. Colleagues, this ends the hearing for this Friday, and we will see you all Monday. Thank you again.